Good afternoon, Dr. Sri Ganesh, for giving me an opportunity to be part of your esteemed course. Going on to my presentation, it is why is SMILE my refractive surgery of choice? Probably I should have been the second speaker, but essentially we all understand that the technology is always on a spur, always there's a change which is coming on. But the reason why it comes on is because there are certain weak links or lacunae which evolve, which needed these answers. And I believe that it is these uncertainties which have always been the breeding ground for newer technologies to evolve. What had happened is over the last couple of decades, biomechanics came to be better understood. And we realized that by creating a flap, or we were sort of compromising on the biomechanics of the cornea, because it's the anterior stroma and the Bowmans which contribute significantly to the tensile strength. And by creating the flap and then by ablating it, you are definitely weakening it. And towards this end, SMILE, although it could have needed more tissue, it still leaves the cornea a lot stronger than LASIK. Again, this is a study which was done by a group wherein they have compared the tensile strength of SMILE, and they have found that it has better preserving biomechanics. The other reason why SMILE has an edge over the earlier refractive procedures is because we all understand that the nerve plexus arborize in the stroma and the subbasal region, and this is the area which gets cut by the microkeratomes, the femtosecond laser, and the excimer laser ablation. So essentially, by going in for a SMILE, wherein it's only about 30 odd degrees of incision which is being cut, you are minimizing the cutting of these nerves and thus minimizing the risk of dry eyes. This is a confocal microscope study which again tells you that there is some loss of nerve fibers, but not proportionate to what is there when you're doing a microkeratome or a femtoflap. Again, it needless to be said that when your fewer nerve endings are cut, the corneal sensation is better preferred. The other main area why SMILE wins over the other procedures is that there is no flap. So when there are no flap, there are none of these flap complications which could occur. But however, having said this, because there is an interface, we cannot rule out the fact that rarely you could have an epithelial ingrowth, a DLK, which has only been one odd study which has been done in literature. So essentially, it is an all-in-one solution. And the huge advantage is it has a high numerical aperture, because of which there's a greater depth of focus, and hence, and also because the repetition rate is as high as 500 Hertz, you could use a smallest spot size, and the energy requirement is brought down to 130 to 150 nanojoules. This is one great advantage. The other advantage is with the femtosecond laser flaps, the applanation is largely it's a planar, a spherical interface, and there is a greater buildup of suction and intraocular pressure, whereas it's a curved applanation with the SMILE procedure. And the other advantage is it actually sits right within the cornea, and it self-calibrates to the K values of the eye. So it's a more optimal coupling which occurs off the contact lens glass to the cornea, and hence there is an intraocular pressure buildup, but it is definitely lower, and because the IOP buildup is less, there is a visibility of during the procedures retained. Again, the docking when it is occurring, the fixation target actually incorporates the manifest refraction of the eye, and thus that's another reason why the visibility is sustained. The other advantage is, I would say that the other femtosecond laser platforms come in with the infrared eye trackers and cyclorotation tracking and all that. None of these things are available with a SMILE. It actually auto-centers on the visual axis. There is a difference, if at all, between the pupil center and the visual axis. In spite of this, you never get a decentered dock. The other advantage with the SMILE is the optic zone is actually nearly a true optic zone, in the sense there is hardly much of a transition area, and on top of it, it's a very planned, the whole lenticule is a wavefront optimized lenticule right from the outset. Whereas with the excimer, because of the peripheral rays which get attenuated, they induce spherical aberration, which is largely significantly less with the SMILE. However, different studies have shown that there are higher order aberrations which are being induced by the SMILE procedure, and probably comparable or a little less than the femtolasic. Again, we all know that the excimer laser is limited, one, by the fluence, the humidity, the temperature, the hydration status. If you are hydrating the cornea longer, the procedure is long, it has an impact on the refractive result, and then you need these nomograms, whereas all of these are obviated with a Visumax procedure. The time taken is barely 25 odd seconds, and the duration of the treatment is irrespective of the refractive error which is corrected. Essentially, the laser pattern is spiral in and spiral out. It's a three-dimensional cut which is occurring. I'm sure you all have been shown this procedure earlier on. Essentially, there's a posterior surface of the lenticule, which is about 6 to 6.5 millimeters cut, then the vertical 90-degree side cut all around, and then the cap cut, which is about 7.1 to 7.5, an extra 0.1 millimeter gets added for the astigmatism, and the lenticule thickness could be as small as 15. It can go up to 30 microns. Going further, again, the smile has a very small chord length of about 30 to 50 as against a flap which has about 280 to 330 degrees. And the size of the contact lens, there's an advantage that you could have a small contact lens if the white to white is less than 12, and you can have a medium sized contact glass if the white to white is more than 12 millimeters. So there are innumerable advantages which have accrued by understanding the limitations of the earlier procedures. But we need to understand there are still concerns that we are able to correct only up to 10 diopter, that is including adding the spherical error to the astigmatism. Only up to 5 diopter of cylinder is corrected. As of now, although it's still studies are ongoing, we do not have a final answer for hyperopia or mixed astigmatism. And the challenges with the row refractive error, especially in your early learning curve, where the lenticule tends to be thick and it's a little challenging to handle it. That's why if the lenticule is very thin, you could increase it to 15 to 30 microns. Going on to a very basic smile procedure, as I would like to add to what was said by my earlier speakers, when you dock, you should see that once the 80% of the docking has done, you press on the foot pedal. You have an infrared illumination which ensures that your pupil center is there, reconfirmed. Then all the cuts are done. And once it burps, you know that the procedure is done. And then you need to just gently grip the eyeball and create a small pocket, plane of separation above the lenticule as is shown and below the lenticule. This is a very critical step, and if you do not go onto the right plane, you might have your lenticule stuck. And then with a blunt spatula, you need to separate the tissue bridges right end, one end to the other. As you can see, a sweeping motion. And if the OBL is not dense, it happens quite easily. Then you need to go underneath the surface. Then again, you would feel more resistance when you're going below the lenticule. You actually see the lenticule folding up if you have separated the tissue bridges. So you have to be persistent about it, and you could ensure that your lenticule has been removed. So as I had earlier said, once you activate suction, once the 80% of the meniscus has expanded, this avoids compression and formation of folds, which actually could disrupt the laser, and you would end up having those black spots. The challenges which are there with the smile is, as you can see, this was a dense OBL, and there are those dark spots. These dark spots appear if there is tear on the surface of the cornea, meibomian secretion, or you have left the anesthetic there and not dabbed it off, or even some debris there. So you would find that the separation of the lenticule gets challenging in these areas. So you will have to be gentle and persistent and completely separate the lenticule, because what would happen is your lenticule could come piecemeal and get torn, as would have been shown to you all earlier. And you would have to pull it in the opposite direction as you would do with a rhexis and get your surgery done. So the prerequisite here is you to have a clear corneal surface. So you need to actually wash the cornea before you do the procedure and place anesthetic drop and mop the conjunctival fornix dry, and then immediately dock it. If you leave the eye exposed, the corneal surface dries up and you could get these kind of dry spots. Again, a superior lenticule, time's up? Okay. So there are n number of things which have proven to be an advantage with the smile procedure, and suction loss, everything has been explained already. So the last slide which I would add is enhancement is very much possible after smile. You could do a PRK, you could use a circle software where you could increase it, change it to a flap and do it, or you could rarely do a LASIK on the flap. So I would like to conclude saying that the technology of smile has gone way forward. We have to cross the initial learning curve, and once we've done it, there's every reason to adopt it as your refractive surgery of choice. Thank you.
Thank you, Dr. Chitra.